Good evening, everyone, and thank you for joining us for an Ask an MPN Expert Facebook Live chat. My name is Andrea Larson from Insight, and I am joined tonight by my colleague, Paul Larson, an oncology nurse educator. Thanks for joining me this evening, Paul.
Thank you.
We're really excited tonight to talk with all of you about general information surrounding those who are affected by myeloproliferative neoplasms. Whether you're a patient or a caregiver, we would like to talk to you tonight about how a community can rally together to raise awareness and positively affect the lives of those affected by MPNs. We're also looking forward to talking with you this evening about the importance of tracking your disease, identifying trends within your disease, and assisting you in talking with your healthcare professional about those trends and how your disease may be changing over time. So before we jump in and get started, I'd like to go through a little list of reminders with all of you. Please keep questions this evening related to MPN-related topics. We cannot provide medical advice this evening. If you have any specific questions about your condition or treatment, please talk with your healthcare professional. Unfortunately, we won't be able to respond to all questions this evening, but we will certainly do our best. And finally, we reserve the right to end the chat early. So prior to jumping in and getting started where we'll talk about the MPNs, first I'd like to make sure to mention that I'd like all of you to be submitting your questions to the live feed below the chat this evening. First, we'll talk about a general information and topics around MPNs, and then we'll move into answering your questions. So get those questions in. We're looking forward to answering them. Paul, can you give us a little bit more information about your role, how long you've been with Insight, and what prompted you to become an oncology nurse educator?
Yeah, thank you, Andrea. I've been a nurse since 1995, so I started out in hematology oncology inpatient nursing and got my nurse practitioner in 1999. So I've been working with hematology oncology patients for over 20 years. I've been with Insight for about 2 years as an oncology nurse educator, working specifically with the MPN community to get more information to healthcare providers and really helping patients advocate for themselves on the MPN community.
That's great. For those of you who don't know yet, you actually may recognize Paul from some of these events. Throughout the year, Insight Corporation and Voices of MPN host patient education events all over the country. We connect MPN communities and give patients and caregivers a chance to speak with MPN experts, similar to Paul here. And they get to connect with other patients as well. Paul, in case we have people watching out there who aren't yet familiar with MPNs or who may be newly diagnosed, can you please provide us with a brief overview?
Absolutely, but first I definitely want to reiterate the success of those programs. We've been going out to different communities across the country, myself and 4 other oncology nurse educators with Insight, and the potential to get patients together all in one room has been fantastic. The patients really enjoy meeting other patients with their disease. Frequently, it's the first time they've met other MPN patients, and it's a nice review of disease state and really gives people an opportunity to meet others in their community with their disease.
That's great.
So to your initial question, definitely MPNs cover a broad range of these hematologic malignancies. These are chronic blood cancers. The ones that we focus on at these MPN meetings with the patients are Philadelphia chromosome negative MPNs, so specifically Polycythemia vera, essential thrombocythemia, and myelofibrosis, which we'll be reviewing tonight for the next hour.
Great, great. Can you go into a little bit more detail about Polycythemia vera?
Absolutely. Polycythemia vera is the most common Philadelphia chromosome negative MPN. There's about 100,000 patients in the U.S. with P vera, typically shortened down to P vera, and it's characterized by an overproliferation of red cells. So this erythrocytosis is really what it's predominantly known for. Extra red blood cells in the bloodstream causing the blood to thicken and setting up the potential for blood clots. It is potentially going to have an impact on other cell lines like the white count and the platelet count, but traditionally, most people with polycythemia vera, you focus on that erythrocytosis.
Great. And can you talk a little bit more about myelofibrosis, please?
Myelofibrosis shares some similarities with P vera in that it is a Philadelphia chromosome negative MPN, but it has some very distinct differences where even though there's this myeloproliferative myeloproliferation. The bone marrow is overproducing cells. A lot of times folks with myelofibrosis actually have cytopenias. They can have anemia. Anemia may be a presenting symptom, or it may be something that progresses the longer one lives with the disease. Both of these are chronic entities, and we really try to facilitate people to have the ability to live and thrive with these diseases as long as they can.
Right.
But with this evolution, things do tend to progress, and sometimes this anemia can come on either at presentation or later on down the road. The P. vera and myelofibrosis certainly have a lot of overlap in terms of symptomatology, itching, fatigue, achiness, and sometimes night sweats and some of these other MPN symptoms that we're going to talk about tonight that are so important to track.
Sure. And then can you just talk a little bit about essential thrombocythemia?
ET, or essential thrombocythemia, is the other Philadelphia chromosome negative MPN that we're talking about tonight. Second in incidence to P. vera, about 80,000 cases approximately in the U.S., a little bit more common in women than men. P. vera, a little bit more common in men than women. And it is also a myeloproliferation. The bone marrow is overproducing cells, and the blood becomes too thick with these extra cells. In ET, there's a focus and emphasis on platelets or megakaryocytes, or what they see in the bone marrow. If you do a bone marrow biopsy on a patient with ET, you're going to see an abundant amount of megakaryocytes, which are the precursors to they become platelets later on in the bloodstream. And so in ET, the patients will have a pronounced platelet count. And the goal is to reduce their risk, because by having this extra high platelet count, they are at a higher risk for blood clots. And similar to P. vera, the other cell lines can be involved. So it's primarily, you think and worry about the platelets, but you do need to keep a close eye on that white count. And in ET, you also want to look at the hemoglobin and hematocrit.
Right. So it sounds like with all three of these MPNs, it's really important to track your disease, to be able to see some of those trends, especially because this is so rare and it would affect every patient differently.
Very much so. They're very heterogeneous. So everybody's disease is going to be unique in and of their own experience. So
right.
One patient's P. vera may be wildly different from another patient's P. vera, and just in terms of its indolence or aggressiveness, in terms of its ability to respond to controlling measures like phlebotomy and P. vera, for instance. So tracking your numbers, having a sense for what your baseline is, what your steady state is, and remember these are chronic conditions. They're not going to go away, unfortunately, so they have the potential to evolve
right.
and transform even. And so we definitely want to encourage patients to have not an obsessive watch on their numbers, but a healthy understanding of what they are, a good sense of what their baseline is, and to note any significant deviations in that, because that may prompt further investigation, and it would be something that should elicit discussion with their healthcare provider.
Right. So you had mentioned that these are chronic diseases, or sometimes we call them progressive diseases. Because MPNs such as polycythemia vera, you may hear us call it PV this evening, essential thrombocythemia, we'll refer to that as ET, and myelofibrosis, which we'll refer to as MF, are progressive conditions. We know that they can change or worsen over time. This is why tracking changes over time can reveal very important insights about your disease and the status of your disease, which can help ensure that they are having the right discussions, all of you, with your healthcare professionals or your healthcare team. I also think it's important to track and look for your trends while you're at home with your caregivers. There may be things that you may not necessarily remember when you're sitting and talking with your healthcare team that your caregiver may be able to support you in. So let's get right into tracking, should we? What should MPN patients be tracking related to their condition, and why?
Absolutely. Just to your point, getting the caregiver, getting family and friends involved is a huge benefit. When you go to the appointment with your healthcare provider, it's hard to remember everything that has happened to you since your last visit, your last encounter with them, and you want to be able to have another set of ears, another set of eyes to share what's been going on in the interval. But mostly, the healthcare provider is going to be very keen on your counts. So you want to have a healthy understanding of those, and they're going to get those from the lab, and then they're going to review them and discuss them. And so you want to, again, like we were saying, significant deviations, if numbers have changed dramatically, that warrants discussion and potential further investigation. But the symptoms are really going to be key for the patients to report on their own, because your healthcare provider really cannot have a sense or send to the lab a symptom panel, right? So that's your job to track these on a scale of 1 to 10. How has your fatigue changed over the last 3 months? If you have pruritus or bad itching, has it gotten better, worse? And a scale of 1 to 10 is an ideal tool to use. It used to be a 3 or 4, now it's a 6 or 7. That's clearly a worsening symptomatology. And then that's really your job to report as a patient, and then it's the healthcare provider's job to assess why that may be and potentially investigate and make interventions.
Sure. So let's unpack some of that a little bit for those who may not be aware. So can you talk about pruritus a little bit more?
Sure. Pruritus is a very miserable symptom in MPN. In my experience, a lot of polycythemia vera patients experience this, a lot of myelofibrosis patients. Others, just like we were saying earlier, how these are so heterogeneous, other people have never had pruritus associated with their condition. Sometimes it's referred to as aquagenic pruritus, so very much exacerbated by exposure to water. Things like hot shower and then toweling after the shower can bring on a significant bout of pruritus. And this is a symptom clearly driven by this cytokine phenomenon that MPN patients experience. They have an abnormality in their hematopoiesis. Their blood formation in their bone marrow is impacted by these mutations that occur in MPN and these blood cancers. But there's also a overstimulation in another pathway that's producing cytokines, these non-specific proteins very much involved in our immunology. And so this excess cytokine, this pro-inflammatory state, can drive a lot of these symptoms. And as the disease progresses or evolves, the symptomatology can change. And so your job is to report those symptoms to your healthcare provider so they can get a better sense for what may be evolving or changing. And also, hopefully, they're going to help address those symptoms, because that's what really makes living with these conditions day to day such a burden in a majority of patients.
Right. And I'd like to remind all of you out there this evening that if any of you are experiencing symptoms that may be worsening, please consult your healthcare professional, as each one of these MPNs may affect each of you very differently. So can we talk a little bit, I know that you were referring to 6 on a scale of 1 to 10 maybe. Can we talk a little bit about the MPN 10 symptoms and why it's important for patients to know them? What symptoms are involved in the MPN 10? Let's talk a little bit about that.
Yeah, I mean, the MPN 10 to me as a nurse practitioner is just a simple review of systems. So when you're a healthcare provider, you go in and talk with the patient, you get what we call a review of symptoms. How are you feeling? You know, activity level. Are you more active, less active? Are you doing the activities of daily living? We'll refer to them. You, on a pruritus, would be on a MPN 10 scale. How is that itching? Or have you developed itching? Or if it's a new patient, do you have itching? If so, how miserable is it?
Right.
Or is it mild? Is it just with the shower? Have you found ways to limit it? Fatigue is the universal symptom that we hear about from MPN patients. Fatigue is a very common symptom with MPN, and in some cases quite profound. Achiness, bone pain is a symptom. And then symptoms related to the spleen are a real hallmark of some MPNs, very much so myelofibrosis. Splenomegaly is quite common in myelofibrosis, and to some degree in the other MPNs that we're talking about tonight, ET and PV. Some degree of splenomegaly can be present. And the spleen is an important organ in our left upper quadrant, very much involved in our immunology and our blood. And in this myeloproliferative state, people can have an engorged spleen. The spleen can get large, and the technical term for that is splenomegaly. And that can cause abdominal discomfort, aches and pains. As it's getting bigger, it can cause early satiety, or you fill up really easily when you eat, and that can lead to some weight loss. So spleen-related symptoms are a key part of the MPN-10 assessment.
Sure. So I know we've touched on several different symptoms, and we've gone through and talked about how they could affect PV patients versus ET or MF patients. Let's talk about each one of those a little bit more in depth. So can we just talk a little bit about some of the symptoms that PV patients could be experiencing? I know some of the feedback that we hear are PV patients tend to not necessarily recognize some of their symptoms. They almost feel like maybe it's a sign of them getting older. Can you touch on that a little bit?
Sure, absolutely. Although I must say that in MPN in general, and that's why it is this umbrella term, MPN, a lot of the symptoms overlap and the diseases share many similarities, and that's why they are in this same classification. So in my experience, ET patient symptoms aren't necessarily all that different from P. vera. Myelofibrosis is a bit more profound in that usually the symptoms that are present in those patients are the same ones but even more pronounced, for instance, the fatigue. But classically, if you think about polycythemia vera, the pruritus is a common symptom in a lot of PV patients. Some achiness to some degree, the fatigue for sure, and just an inactivity, a less activity than one was doing previous to diagnosis. Mm-hmm. It is unfortunately common for people to attribute their symptoms to something else. Oh, I'm aging, or I have this other, I'm too stressed out at work or my home life. And a lot of times in hindsight, people realize that these symptoms are directly related to this malignancy. About a third of patients are diagnosed through symptomatology. Another third are diagnosed through just routine blood work. So that kind of points to how some are more symptomatic than others. And then the final third are diagnosed through an event. Obviously, the biggest thing that we want to prevent in MPN is these blood clotting events. And so some patients are diagnosed because they had a heart attack or a stroke or a deep vein thrombosis, one of these blood clotting events. So, but P. vera, really classic for the fatigue, the itching, essential thrombocythemia in my experience. A little bit more complaints that I've heard about regarding headaches, sometimes that foggy brain, cognitive symptoms, definitely fatigue, and then myelofibrosis, usually a really profound fatigue. Symptoms related to splenomegaly are really a hallmark of myelofibrosis. Some easy bruising, bleeding events can occur in all of these entities, but ET and myelofibrosis, in my experience, a bit more bleeding and bruising events.
So it sounds like their quality of life is really affected.
It can be, very much so.
For those of you who are just joining in, you are on the Ask an MPN Expert session this evening. I am Andrea Larson. I work for Insight, and I am here with my colleague, Paul Larson, who's an oncology nurse educator. Just as a friendly reminder, if you want us to answer any questions that you might have this evening, please add those questions to the chat box below the live session, and we'll get to those shortly. So I know we talked a little bit about quality of life being affected, and I know that we've talked a lot about tracking. Can you maybe give some information around how caregivers can support patients within their home around the quality of life that's affected? Is there anything that a patient can say to their caregiver to let them know that maybe they're not having such a great day based on some of these symptoms you've mentioned?
So kind of the caregiver's role?
Sure.
Yeah. I think that it'd be ideal for a caregiver to have a sense for one's nutritional status. Sometimes if we're eating less or not eating as well, we notice that less ourselves. Okay. So you might just keep an eye on their intake. If their calorie intake is reducing, it would be something to bring up. And your healthcare team may have a nutritionist that they could speak with. If you're going to have early satiety, if you're going to fill up quickly, let's make sure you eat the right foods to get the healthiest amounts of calories that you can get. Fatigue and just this sense of, oh, I'm getting older, or not knowing that you're doing less. So a caregiver can kind of gently suggest that, you seem like you're taking more naps and things like this. And, it's just sometimes I think we're the last ones to know when we're acting differently and doing things differently. So I think just that extra set of eyes and ears can share to the discussion and even bring to light to the patient themselves Oh yeah, that does seem different. Activities, nutritional intake, and maybe even mood, in terms of anxiety or, your outlook on life. How much is that changing living with this chronic condition?
Sure. So earlier you had mentioned the importance of tracking blood counts, and we've talked a lot about the importance of tracking. Can you talk a little bit about what some of the health trends patients should be looking for when they're tracking their disease?
So, the key thing with your MPN is what did it look like at diagnosis? And so I know not everyone out in the community is getting bone marrow biopsies. The World Health Organization does recommend at this day and age a bone marrow biopsy at diagnosis. But if you've been diagnosed and you're under care, I'm certainly not suggesting that anyone go get that at this point. But what my point is, why I thought about the bone marrow is having a sense of what's your baseline. So if you know what you were presenting with, what was your hemoglobin, your hematocrit, what was your platelet count, what was your white blood cell count, and then tracking that. Obviously, your healthcare team's making interventions to try to get those numbers to a better range, whether they're too high or too low, however they're going to advise you to do that. And so your job is just to have a healthy sense of where they are and be able to bring up a discussion if they're changing dramatically. A common phenomenon in this day and age with chronic conditions and people who really are potentially enjoying their golden years, they're retired perhaps, and they're a snowbird. So they may be only spending half the year at quote-unquote home and the other half of the year somewhere south, and so they're transitioning from one healthcare team to another. So they really, I think, need to advocate for themselves because the healthcare teams are only seeing them half the year, and they're not going to have as good a sense for changes in their hematocrit, changes in their platelet count. And so a well-informed patient is ultimately going to lead to better care because that patient's going to really be able to advocate for themselves to their healthcare team. In myelofibrosis, they may be getting blood transfusions. If they're getting blood transfusions at different sites, it may be hard for the healthcare team. They may be covering each other or signing orders for each other. It's hard for them to have a sense for how many transfusions are you getting, but it's very easy for the patient to track this and then report it. I used to get a transfusion once a month, now it's twice a month. Why would that be?
Right.
Would be a fair question for them to bring to their healthcare team. Why am I needing more transfusions?
And I think something that you touched on that's extremely important is the fact that they may have more than one member of their healthcare team. They may have several. So what's really important for patients is to make sure that they're tracking and being their own advocate when it comes to their disease, looking at those changes and asking the appropriate questions.
Absolutely. And to your point about having multiple healthcare providers, I was thinking in just their hematology practice alone, and if they travel, they may have multiple hematology providers. But then they've got a whole other boat full of providers for other specialties. They obviously have other health potentials and may have other specialists. Accidents can occur and you end up in the emergency department and they might not know anything about your MPN. So really a well-informed patient and a patient that can advocate for themselves can really save themselves a lot of trouble and potentially prevent more serious outcomes that would have occurred otherwise. So making sure that they communicate to an emergency room specialist, for instance, this is my hematologist's contact information. If you have any questions about my blood counts, please call them so that you can talk with them directly. If they're going to the dentist and they need routine care, or perhaps something not routine, an intervention of some form, please talk to my hematologist first. Bleeding and blood clotting is a risk with these diseases. Going in and doing procedures raises that risk. So making sure all these providers and specialists communicate together. Sometimes they don't do it on their own, but if a patient helps facilitate that, it's more likely to happen.
Right. So continue to be your own advocate. Yeah. So you've touched on this a little bit. Can we talk a little bit more about the importance of tracking and how that may come into play when patients have different medical procedures?
Well, tracking for procedures, I can't really think of any specific things. Anticoagulation, if somebody's taking an aspirin, there's going to be communication with the healthcare team. I don't want to lay too much of that on the patients, but I think that making sure that the docs and nurses talk to each other is kind of where the responsibility ends for the patient, and then the healthcare providers will make the recommendations that are appropriate to make. But in terms of tracking symptoms, really reporting that, because unfortunately these diseases can transform. So polycythemia vera and essential thrombocythemia can evolve into myelofibrosis. And unfortunately, all three of them have a small but real potential to evolve into acute myelogenous leukemia. And so it's really key that the patients and the healthcare team are aware of changes so they can investigate further. So if you're seeing significant changes in your complete blood count, your CBC, it would warrant further investigation. And the best place to do that would be in the bone marrow itself. Taking a look in the marrow to question if there's been evolution or transformation of this disease. Or did something else happen? If you've had a dramatic change in your hemoglobin, hematocrit, was it from a transformation or did a bleeding event occur? So there's lots of things that can bring about changes in our blood counts or our blood chemistries. And then, again, it's not the patient's job to figure out what this is. It's their job to report how they're feeling and to have a sense for what's my normal, and when that normal changes, making sure the people overseeing your care, investigate it and aren't aware or neglect it.
Sure. So how about tracking different procedures that are frequent for each of the three MPNs? For example, should patients be tracking the frequency of phlebotomies that they may be having if they have polycythemia vera?
Sure, I see what you meant about procedures now. So certainly therapeutic phlebotomy is a common therapeutic intervention for polycythemia vera. So having a sense for how many phlebotomies you're having. If you used to only have 2 or 3 a year and now you're having 4 or 5, why is that? Is a medicine that you've been prescribed not doing its job, or are you not taking it? Could be multiple reasons. And so just having a sense for, I'm doing more phlebotomies, or am I doing less? I used to always get 2 or 3 a year, and now I haven't had any in a while. Why may that be? And sometimes the healthcare provider is not aware. They're doing their visit with you and having a review of systems, a healthy review of systems, but not completely aware of your flow of these procedures like phlebotomy or transfusions in myelofibrosis. I'm getting transfused more. Now I'm needing platelet transfusions. Right. Why would that be? And in essential thrombocythemia, it's very rare and atypical to have a aphoresis procedure, but some folks do have the potential to have this aphoresis procedure that will bring about a rapid reduction in their platelet count. And if they were utilizing that as an intervention, they would want to have a sense for how often they were doing that.
Sure. Can you talk maybe a little bit about the importance of using online trackers or how they may be effective when tracking your disease? I know that we've talked a little bit about you don't have to go crazy and track every single thing, but at the same time, it should be something that becomes very routine and second nature to you. So can you maybe talk a little bit about the benefit of online trackers?
I think it's just something that keeps it all organized in one place, in your pocket with your device. And if you can utilize these, if you're old-fashioned, pen and paper is fine, but sometimes that's harder to remember or to transition if you're going from different sites of clinic. Certainly some people will enter things rather methodically and have charts and graphs. I think that that's not necessary, but if somebody did that, I'm certainly not going to fault them on it. But just having a sense for what's your baseline, and then being able to track these trends.
Sure.
And so there are some wonderful tools online that one can use now. It's just convenient and easy, so why not use it?
Right. And I think it's also an easier way to share it with your healthcare team.
Absolutely.
And also with caregivers, just in case they're in different locations and they all want to be kept up on a family member or a friend's updates.
Right.
So I think that's really important. I think that we're going to open it up to some of the questions that we've received online. We're really excited for that. So if you guys could continue to submit questions, we're really going to try to answer as many of them as we can this evening. So first we have a question that came in from Betty. It says, I have PV and ET. Can you tell me the importance of watching ferritin levels?
Oh, so the ferritin is a very I want to say nonspecific, but it is a marker of your iron stores. But it is highly sensitive to other things that can impact it. So you would never want to assess a ferritin when you had a bad cold, for instance, or pneumonia, an acute event, because your ferritin is going to be falsely elevated. But a ferritin is a very helpful test at steady state to know what your iron stores are. And in polycythemia vera, a common therapeutic intervention, as we discussed, is therapeutic phlebotomy. It will help get those red cells down and reduce the risk for these blood clotting events. It will lower the volume of these blood cells. But by doing that, the bone marrow replaces these cells. Anytime we bleed or have blood removed, our bone marrow wants to replace it. And obviously in MPN, there's a drive to produce these cells in overdrive already. And this, you have to have iron to produce red blood cells. So in essence, through treatment, a goal to reduce the blood counts, to lower the risk for clotting, we could make someone iron deficient, a healthcare provider when I say we could. And so iron deficiency has symptoms and can make one not feel well. So a ferritin is a good sense for what's a healthy range of iron storage and what is getting too low.
Great, thank you. For those of you who may have just joined the live portion of this session for the Ask an MPN Expert, my name is Andrea Larson and I work for Insight, and I'm joined tonight by my colleague Paul Larson, who's an oncology nurse educator. Thank you for joining us. The next question we received is from Janice. It's, is polycythemia rubra vera the same as polycythemia vera? And is there a correlation between ITP and PV?
So yeah, I mean, P vera is P vera. I think that's just a terminology difference. There is an important distinction between polycythemia vera and polycythemia, though. There's a lot of patients who have polycythemia, and they do not have an MPN. They are not here in this discussion that we're talking about tonight. There's lots of things that can cause polycythemia, and this would be what's referred to as a secondary polycythemia. So something that's driving an extra, in most cases, red blood cell production, things like testosterone supplementation or altitude changes or COPD, emphysema. Your body is sensing it's not getting enough oxygen, sleep apnea, so it's producing more red cells. So it's very important to distinguish between secondary polycythemia and polycythemia vera, but P vera and the P rubra vera are the same.
Okay.
Yeah.
We have another question that came in from EK. Thank you for your question. Can you be diagnosed with ET and have PV symptoms, or do you just progress to PV?
So MPN symptomatology, they definitely overlap. So a lot of the symptoms in P vera and ET are similar. But most importantly, everyone's case is very unique in and of themselves, in my experience. So I've never seen two MPN patients that were identical. So everybody's case is different. So if you have, in this situation, you were talking about ET and can you have PV symptoms, you definitely can, but in the same train of thought, you can have PV and have ET symptoms, and myelofibrosis. The symptoms are very similar and overlap in all of these entities. You can have ET and transform into PV, and you can have PV and ET that will transform into myelofibrosis, and sometimes a sense that when that's occurring, symptomatology may be evolving or changing, and that's one reason why we're emphasizing the importance of tracking your symptoms and these trends, because it could be a representation of some change in your disease status.
Sure. And as we've mentioned before, it's always important to note that if your symptoms continue to become more severe or worsen, you can either contact emergency services or reach out to your healthcare professional. So thank you for joining us tonight, Carol. We have a question from you. I want to know if you can progress from ET to PV, then a third stage before going to MF. Is there any way to slow the progression down?
That's a great question, Carol. You can transform from ET to PV, and I'm not familiar with a third stage before going to MF. So typically if you're, the only way you're really going to know is to look in the bone marrow and have your hematopathologist take a look at things under a microscope to clearly define if somebody has evidence of myelofibrosis. But so to answer your question, absolutely ET can become PV, and both of those can become MF, but I'm not familiar with any interim stage.
And you've talked in the past about the importance of creating that baseline. So this is why it's also important to track so that you can continue to see if your disease continues to progress.
Sure. I mean, sometimes the bone marrow is a formality. If somebody has transformed or progressed, they already know. Sometimes the patients know, have a sense even before their healthcare provider, and then the bone marrow just kind of confirms what everyone's feeling in their gut.
Right.
Yeah.
So we have another question for you, Paul, from Philip. What is platelet aphoresis?
So platelet apheresis is that very rare procedure that I was referring to, and thank you for asking because maybe I didn't shed enough light on that. In my experience, not utilized very much in ET at all, but it is a rapid, so if you donate platelets, say you go to the Red Cross and you have healthy blood, if you have an MPN, unfortunately you cannot donate, but I encourage your family and friends with healthy blood to donate because all blood cancer patients need healthy blood for transfusions. And sometimes, mostly people donate red cells, but they can donate platelets. And there's a machine, I don't know the name of it, but it's a fancy machine that your blood goes out of you into this machine and it spins the blood and it will collect the cells that we have asked it to collect. This technology is amazing. Mm-hmm. So when stem cell transplant is utilized, these machines will collect the stem cells. And in this situation, it can collect those platelets and then, if for donation, save them for donation, or in the case for ET, if this is a therapeutic apheresis, it will get a very high platelet count down rapidly with this machine. So it will take the platelets off, blood goes into the machine, spins it, takes the platelets off, puts the rest of the blood, plasma, red cells, white cells back into the person, and we'll get that platelet count down quickly. And again, in my experience, not utilized very much for management, sometimes utilized in an acute setting. But it's certainly possible that people that they're doing this for their disease management in ET.
Well, something that you mentioned that I would like to just capitalize on, we have caregivers all the time who ask what they can do to help support the MPN community. And you mentioned that blood donations are always something that can help anyone in need of any type of blood donation. So I think that that's something important to note too. We hear that a lot through those patient meetings that we discussed earlier.
Absolutely. That's kind of my little soapbox thing. I donate my red cells when I can, and I think that family and friends want to help. They say, what can I do for you? And you kind of just sometimes, we're all good. I appreciate your thoughts, and sometimes you just you want to know that people want to help, but sometimes there's not a whole lot for them to do. And so that's something you can tell them. Hey, please go donate blood. It's going to help potentially me and definitely other patients.
That's great. Just a reminder, if you could continue to submit any of the questions that you may have, Paul's ready and willing to answer those questions here up with me today. So we have a question that came in from Liz. If I have to have any type of surgery and I have ET, are there any concerns that need to be discussed with my healthcare professional?
Absolutely. That's a great question. So any surgery that you're going to have, no matter how minor or major, the surgeon and your hematologist, your blood cancer specialist should be having a discussion. Unfortunately, the risk for bleeding and blood clots in MPN patients is greater than normal. And bleeding and blood clot risk is high to start with for all of us when we have procedures. So it doesn't mean you can't have procedures. You're a higher risk surgical candidate, but you can still do these things. There just needs to be coordination and discussion amongst all the specialists and healthcare providers to lower your risk for these bleeding and clotting events that can occur in that acute setting.
Right. Again, advocate for your own health and make sure that you track and let everyone who's a part of your healthcare team know.
Absolutely. As long as everybody's communicating, patients are going to get the best care. Might be something that it was an outpatient procedure for someone else. You might spend the night in the hospital, no big deal. Whatever it takes to get things done and lower your risk for these complications, that's how things can still get done.
Great. So thank you for submitting your question, Paula. Is there a correlation of the effects on hepatocellular carcinoma with ET?
So is there a correlation on the effects of hepatocellular carcinoma with ET? The effects, I must confess I'm not too up on hepatocellular carcinoma, but solid tumors and blood cancers certainly can occur simultaneously, or we talked about these MPNs are chronic conditions. You may live with them for years and years and everything's going swell, and then you develop another disease, and that other disease could be another cancer. And so certainly these things can occur. And again, why it's so important to track and trend. So if you're having new symptoms, new changes in your blood's counts or chemistries, it could be your MPN changing, or it could be something else happening. And the first thing that I think about when I hear about the liver, anything hepatocellular, the liver is key in platelets. And so anyone with liver disease can have a significant change in their platelet counts. And so hepatocellular carcinoma, ET, I don't feel that there's any direct correlation, but the care and the management of both of these could be compounded, but certainly, again, communication, you would probably have a hematologist with the ET and a solid tumor specialist with the hepatocellular carcinoma, and it would be key to really keep a close eye on platelet counts, obviously. But in terms of, if the question is there a correlation of the effects? Certainly, as I mentioned, they both are platelet-related. The bone marrow is impacted in MPN, driving platelet changes. The liver is a key organ in platelet production, so certainly they can be intertwined in their management, but I'm not familiar of any correlation in terms of their incidence.
Okay. Paul, Teresa has a question for you. She wants to know, are headaches experienced with MPNs?
Headaches are quite common in MPNs, unfortunately, and in my experience, a bit more in essential thrombocythemia. Can be a real challenge for some folks. So tracking these and having a sense, headaches are a challenge in any person who has a chief complaint of a headache. But if that's one of your MPN symptoms, get a sense for what your baseline is. Know what interventions make it better. Know what interventions make it worse, and really work together with your healthcare provider in terms of minimizing these. We may not be able to make them go away completely, right, but hopefully with thoughtful and thorough discussion and evaluation, we can minimize them and give you strategies to help manage them when they do occur. Okay.
We do have a question from Eileen. Is tiredness one of the symptoms? And I know you've talked about some of the symptomatology crossing over between all three of the MPNs. So maybe you could talk a little bit about how tiredness may affect some of the different MPNs.
Tiredness is the most common MPN symptom, or fatigue. And in terms of its evolution, certainly we're all prone to having good days and bad days. But you want to have a sense for, is my fatigue getting worse? And why is that? And so you can use that as an example in terms of that MPN 10 scale activity level. Are you doing less? Are you missing more events, more social and family events? Are you less active? And so that can be hard. That can sneak up on you. And we have a powerful sense of denial in terms of symptoms. No, I'm fine, don't worry about me kind of mentality. And so helping people track this, so the only way to do that is with a log, with a diary, with these tracking tools, and having a sense for, no, this is definitely getting worse. This is not my imagination. And the fatigue is real. And unfortunately, we hear all too often that MPN patients are told their symptomatology doesn't warrant that degree of symptomatology cannot possibly be related to their disease, and it clearly is. We see this across the MPN spectrum that these symptoms occur to great incidence and great degree, and so reporting them and sharing them with your healthcare team, and then coming up with strategies. And sometimes those strategies are just changes in lifestyle can have a big impact. And then obviously controlling the disease is your healthcare team's job, and sometimes the better your disease is controlled, the less your symptoms can be challenging to you. So, to answer Paula, the question, I can't remember whose question it was. Eileen's just, is fatigue common? Extremely common, and very, very pronounced in myelofibrosis in my experience, but really shared throughout the MPN community.
Great. The next question we have is from Paula. Is a peptic ulcer an example of bleeding associated with ET?
It is, yeah, absolutely. So gastrointestinal bleeding, and that's something you can be less aware of. If you're bleeding from your nose, that's pretty obvious. If you're bruising easily, that's more obvious. But if you're having internal bleeding, gastrointestinal bleeding, that's harder for you to appreciate. And so hence why it's important to track your counts, because if you're bleeding gastrointestinally, you're probably lowering your hematocrit and hemoglobin, and keeping a sense on your any bathroom changes. If you're having changes in your stools, if you're, my goodness, if you're vomiting blood or having anything like that, you want to seek medical attention immediately. And if you're having GI symptoms, maybe related to your spleen, but maybe something else. So all of these, other things can occur, and so your job is to report it, and then it's your healthcare team's job to figure out what it could be related, why it may be occurring.
Sure. Summers submitted a great question. Does age play a major part of prognosis with MPNs? So maybe we could talk a little bit about the age range, usually related to each of the MPNs. And then the second part of her question is more around an example. The younger you are when diagnosed, is your prognosis better or worse?
That's a complicated question. It's obviously a great question and an important question. In terms of prognosis, age plays a role in polycythemia vera. We stratify people low risk or high risk, and one of the qualifications for high risk is age over 60. So if you've had a blood clot, or if you're over 60, you're high risk. So if you are under 60 and have not had a blood clot, you're going to be lower risk. So in some degrees, unfortunately, age, it certainly does have an impact on prognosis. In your healthcare team's ability to be aggressive with management, sometimes age can be a limiting factor. The older we are, the more baggage we bring in terms of other conditions, maybe harder lung conditions that could potentially limit their options for your disease management or treatment. I think she had a question in terms of being younger. Obviously, our younger patients, typically we hear about these diseases occurring over the age of 50 and 60, but everyone out there knows we have lots of young MPN patients, and certainly the younger folks these are chronic conditions. They're not going to go away, unfortunately. The younger you are, the longer you're going to live with it, and so I don't think that has any significant, that I'm aware of, impact on your overall prognosis, but just the longer you live with it, the more that windows open for this evolution, transformation, and things like that. So, but obviously younger patients bring less other diseases to, otherwise have good health. So I think there's pluses and minuses.
And this is why we've mentioned in the past that each of these diagnoses are so unique to each patient that they should be really tracking and having those conversations specifically with their healthcare professional about their disease.
Absolutely. Yeah.
So the next question we have is from James. What should I know about blood counts and PV? And you talked a little bit about complete blood cell counts earlier, right. So maybe it would be helpful to talk a little bit about exactly what they should be looking for when someone has polycythemia vera.
Yep, with polycythemia vera, you look at the hematocrit. Classically, people come in with a very high hematocrit. Potentially, you're looking at their hemoglobin as well. These are both reflection of their red blood cell burden. And a target hematocrit in this day and age is under 45. So you look at the hematocrit in polycythemia vera blood counts. You want it under 45, but it's important to remember you want to look at all three cell lines. So you think of polycythemia, it's very descriptive right there. Cythemia is high in poly. So there's multiple cythemias. White count could be elevated. Platelet count could be elevated. So You don't look at just the hemoglobin hematocrit. I think we need a complete CBC. We need to look at the white blood cells as well and the platelets. Are they above normal? If they are, unfortunately, the disease is not optimally controlled. If they were previously normal and now they're escalating, why would that be? So that's something that you could pick up if you're tracking and trending your numbers, and then that should elicit discussion. You know, hey doc, I used to always have normal white count and platelet count. My hemoglobin, hematocrit have been good, but I'm noticing those other cell lines are creeping up. Why could that be? It should generate discussion and may prompt further investigation. It could be something related to your MPN, or it could be something else. So that's their job to figure out.
Sure. Just as a reminder for any of you who may have joined, my name is Andrea Larson with Insight, and I am joined here with my colleague, Paul Larson, who's an oncology nurse educator. We have about 15 minutes left, and we're really enjoying answering all of your questions, so please feel free to submit, and we'll try to answer as many as we can. So, Paul, earlier you had mentioned splenomegaly, an enlarged spleen. Jeremy has a question. Do MF patients always experience an enlarged spleen?
No, they don't always. And it may be to a varying degree. So some people have very significant splenomegaly. Some may have mild to moderate splenomegaly. And probably just as importantly, or maybe even surprisingly, some people aren't aware that they have splenomegaly. Some people have symptoms of fullness, achiness. Other people are completely unaware that their spleen is big. It should not go below your rib cage, and by definition, any spleen that is below the rib cage is splenomegaly. And so was the question, does everyone have it? Certainly not, but in myelofibrosis, the majority do have some degree, but the degree of splenomegaly is highly variable. And your sense of it may be limited. Your healthcare provider should be percussing and palpating your spleen. If they are not successful at doing that, perhaps you have a larger abdomen. Ultrasonography can evaluate splenomegaly. I don't think other tests are warranted. Sometimes on clinical trials, MRIs are done, but really a physical exam will usually suffice to have a sense for what's my baseline spleen, what's my baseline splenomegaly, and is it getting better or worse? If it's getting better, let's keep doing what we're doing. If it's getting worse, why would that be? And again, the patients may not fully appreciate how much splenomegaly they're actually walking around and living with.
And palpating is that physical exam that you were referring to?
Yes, pushing. They should be having you lay flat and pushing on your abdomen and getting a sense for where your spleen is. That's kind of why I'm doing all this nursing stuff.
So we have a question from Judith. What's the importance of bone marrow testing?
You know, bone marrow testing is a little, I don't want to say controversial, but highly variable. So the World Health Organization did update their MPN diagnosis criteria, and in this day and age, they do recommend a bone marrow biopsy. It's the only way you can diagnose myelofibrosis because you need to see that fibrosis in the marrow. But a lot of patients have essential thrombocythemia and have polycythemia vera, and they've never had a bone marrow, and that's okay. You know, that happens. It doesn't mean they're getting poor care. It just means that their healthcare provider didn't feel it was warranted. Again, in this day and age, they recommend it as a baseline. My bias is that having it is a nice baseline. Again, for that track and trend, you're going to live with this disease potentially for the rest of your life, and you want to know where it was like at baseline. A lot of academic centers are more prone to getting bone marrow biopsies. Sometimes out in the community, they feel less inclined. And if you have not had one and your disease is currently diagnosed and managed successfully, you know, it could certainly be a fair question to ask your healthcare provider, how come I didn't have one? Should we do one? But I think that if things are pretty stable right now, the likelihood that it would be indicated is relatively low. It would be something that could be useful if we see, like we were talking earlier about these changes. That's the only way you're going to really know what's driving some of these changes is actually looking in the marrow itself.
Right. We actually have a follow-up from Summers. Are immunizations important with MPNs?
Ooh, that's a good question. You know, I'm going to chicken out a little and have you defer that to your healthcare provider. I mean, The immunizations, most of them we get as kids. And then in terms of boosters and things like that, I think that's going to be variable to your case and your care. But great question to bring to your healthcare team.
And now I have a question from Carol. Can you speak to the life expectancy for myelofibrosis?
It's highly variable. These are all chronic conditions, and based on where you are, we can do some prognostication in terms of initial diagnosis, and as that's moving, we have some prognostic tools and models that we use, looking at your blood counts, looking at the types of cells, factoring in how low things are, and then coming up with some computation of these numbers. But it's highly variable from patient to patient.
Okay. These questions are rolling in. We have another one from both Summers and Rosella. Is numbness and tingling a symptom associated with MPNs?
It is, yeah. Tingling, so erythromelalgia is a fancy medical term for pain, burning in your hands and feet. As those blood cells are going into those smaller vessels in your periphery, they can cause this numbness, tingling, and discomfort.
Great. Kathy says, will having an MPN make someone more prone to acquiring other cancers?
Well, unfortunately, anyone who has a cancer has an increased risk for other cancers. I'm not familiar with any specific, I have this MPN and now my risk for cancer X, Y, or Z is exponentially increased. I'm not aware of anything, but in terms of anyone that has one cancer, they've already kind of opened that cancer door, so to speak, and so the risk for other cancers is slightly higher in this population.
Sure. And again, that's probably why it's always so important to continue tracking and advocating on your own behalf so that you can have those conversations with your healthcare professional.
Sure.
The next question we have is from Kathy. Are there any comorbid conditions that seem to be common among MPNs?
Well, not that I'm familiar with, but certainly other comorbidities with an MPN makes one's risk for the biggest thing that we worry about is these thrombosis or clotting events. So if you also have cardiovascular disease or type 2 diabetes, hypertension, obesity, your risk for these clotting events plus an MPN is these other comorbidities do add to the risk, unfortunately.
Okay. We have a question from Shannon. What should MPN patients be tracking related to their condition and why? Tracking seems to be a trend this evening.
So tracking the symptoms, so MPN 10, fatigue, itching if you have it, activity, spleen symptoms, nutritional symptoms, aches and pains, night sweats, weight loss, your general ADLs, activities of daily living, your blood counts, so knowing what my normal hematocrit is, or quote unquote, my baseline hematocrit. I'm generally under such and such a level. The healthcare team makes intervention XYZ and it keeps me there. Now it's changed. Why could that be? So keeping a sense of your symptoms and your blood counts is really what you want to track, and then get a sense, is there a trend? Is there a deviation from that trend? Should prompt discussion.
Sure. And then any thing you might have, like a phlebotomy.
Definitely, the medicines or interventions that are done, tracking those.
Sure.
In addition, changes in dosages of medicines or incidence of interventions like phlebotomy.
Sure. This is unfortunately the last question. We have been having so much fun speaking with all of you this evening. So Diane, can you discuss ocular migraines and polycythemia vera?
They unfortunately can occur. Headaches, just a more specific a more specific definition of your headache. I'm not familiar with the specifics in terms of the incidence or how best to alleviate them, but headaches and MPNs increase the incidence of headaches and sometimes the severity. And hopefully through management of your MPN, that's going to help manage your headaches to some degree. Headaches are a challenge. They're a really tough symptom. So that's the best kind of remarks that I can make about them. But definitely don't let anyone tell you it's not related, because it likely is. And ultimately, the best thing in medicine is, treat the cause. And so if you think that your headaches are worse when your MPN is less well controlled, you're probably right. And so really managing your MPN to the best of your ability usually will help result in better symptom management.
Okay. So that was a great discussion this evening, don't you think?
Thank you, yes.
Thank you to everyone who joined in and asked questions. We really enjoyed this evening. Paul, thank you so much for joining me.
Thanks, Andrea. Thanks for all your questions, and we look forward to seeing you potentially at one of these events.
Yeah, that concludes our Ask an MPN Expert discussion. Thank you again, everyone, and we hope you have a great night.